Very many thanks for your invitation to speak today in this conference about right heart catheterization. I will share my screen now and start my presentation. Share and start my presentation. So, what is the purpose of right heart catheterization? Obviously, it is to measure pressures on the right side of the circulation, measure cardiac output and pulmonary blood flow, and we will talk about the methods for achieving this, calculating pulmonary vascular resistance, and also systemic vascular resistance, but mainly pulmonary vascular resistance if you're dealing with patients with pulmonary hypertension, and of course to detect and measure intracardiac shunts and assess valve disease, coronary artery disease, and perform pulmonary angiography when necessary. The right heart cath is a fundamental part of the management of patients with pulmonary hypertension, and is the bread and butter of any pulmonary hypertension and other congenital service. Let me just go back to some basics about the definition of pulmonary hypertension. As you know, the definition of pulmonary hypertension has gone from 25 to 20, so above 20 millimeters of mercury. This is the old definition and still is in the guidelines. Let's not forget that. So this should be more equals 25 millimeters of mercury. Now it's more than 20 millimeters of mercury. And this is the reason, because we know that normal pulmonary pressures at rest are low, well below the 20s. And hence, if you go by 2 standard deviation, you should have your threshold for pulmonary hypertension at 20 and not 25. Going forward with the definition of pulmonary hypertension, when you do your right heart catheter, you do this to distinguish between pre- and post-capillary pulmonary hypertension, and within post-capillary pulmonary hypertension to see whether this is isolated or combined. We will go through this in more detail further on, because this is very important for understanding right heart catheterization and interpreting the data while you're performing the right heart cath and afterwards together with all your information. You all know that we use tricuspid regurgitation gradients to assess patients with suspected pulmonary hypertension, and we use the peak-TR gradient and transform it with the Bernoulli equation. The current guidelines, 2015 pulmonary hypertension guidelines, tell us how to interpret the velocity of the tricuspid regurgitation and how to classify patients into low and intermediate or high risk of having pulmonary hypertension, and hence deciding on whether to proceed with a right heart catheterization. It is not just about the tricuspid regurgitation Doppler, it's also about other parameters in the echocardiogram relating to the right ventricle. Of course, if the right ventricle is dilated, if there is an eccentricity in this flattening of the ventricular septum, if there is pulmonary artery dilatation or short acceleration time in the Doppler, in the pulmonary Doppler, and of course looking at signs of raised central venous pressures like inferior vena cava and the right atrium. If you look at the updated algorithm for assessing patient pulmonary hypertension, which comes from the World Symposium 2 years ago in Nice, that tells if you have a patient with history and symptoms suggestive of PH, of course the echo is the first thing you should be doing. Then you should be going on and doing some other tests to exclude lung disease, of course left heart disease with the echo, thromboembolic disease with VQ scan, but then it is important that you go on to more advanced testing investigations, including the right heart catheter. And why is that? Because we know that the right heart catheter is the only way to make a definite diagnosis of pulmonary arterial hypertension and pulmonary hypertension in general, actually. So there is no definition of pulmonary hypertension. There's no patient that can be defined as having pulmonary hypertension unless they have had a right heart catheter. This is the rule. Indeed, you can see if you relate the tricuspid regurgitation gradient to the mean PA pressure, yes, there is a strong correlation, but there are areas where there is no correspondence and we need to be very careful. We have lots of false positives and false negatives. So once you've done the first assessment, you should be sending your patient to an expert center where they can complete their investigations, but mainly And this is the basis of everything, having a right heart catheter to diagnose the pulmonary hypertension and decide on the management. The recommendations for right heart catheterization in pulmonary hypertension in the guidelines are to confirm the diagnosis, group 1C. It should be performed in expert centers, group 1B. It should be used to look at the effect of drugs. So once you've diagnosed and treated the patient, to see if you had an effect. Not everybody does that, but of course, if you think that there has been a sufficient response to therapies, yes, you should be thinking about repeating the cardiac catheter. It is important for cardiac shunts with pulmonary hypertension to distinguish between increased pulmonary blood flow and raised pulmonary vascular resistance, and we will discuss this. And also, of course, when you decide about transplantation, not only for pulmonary hypertension, but for heart transplantation for congenital patients as well. Don't forget that the hemodynamics, invasive hemodynamics, are part of the risk stratification table that we are invited to use by the guidelines when we are managing our PH patients, and it includes right atrial pressure, cardiac index, and mixed venous saturations. Right heart cath hasn't changed much over the years. Various centers use various axes, femoral axis, from the arm, basilica, cephalic vein, or from the top, internal jugular vein. And the Swan-Ganz catheter hasn't changed much, even though not everybody uses thermodilution, and now they're much softer and much less traumatic. Again, going back to this important table, once you have the diagnosis of pulmonary hypertension and mean PA pressure above 20 nowadays, you need to look at your pulmonary vascular resistance and your wedge pressure, of course. We will look at the definition of pulmonary vascular resistance now, but look, it is now contained in all three groups, the pre and the post-capillary, both isolated and combined. You need to calculate your pulmonary vascular resistance. And 3 is the cutoff that we use. Now, for those who don't remember the formula, it's not easy to remember. One trick I use is remembering Ohm's law that we all studied very thoroughly in school, saying that if you have a resistance and a battery and you have flow through the circuit, the resistance equals the voltage, so the power that brings the current forward, divided by the current. In this case, we've got the lungs or the systemic circulation, and you have the right ventricle or the left ventricle, you have the lungs or the systemic circulation, and hence the pulmonary vascular resistance is the transpulmonary gradient, so the pressure gradient that pushes flow through the lungs or pushes flow through the body, divided by the flow through this organ. In the case of PVR, it is QP, it's pulmonary blood flow. In the case of SVR, so systemic vascular resistance, we need to have the QS. And this is the same when you don't have a shunt, but if you have a shunt, QP and QS are different. Another important thing to remember is that when you index your pulmonary vascular resistance, you need to multiply, not divide it by body surface area. Sounds counterintuitive, but if you think about it, we said PVR is the transpulmonary gradient divided by pulmonary blood flow. Indexed, it will be divided by pulmonary blood flow index, which is pulmonary blood flow divided by body surface area, so it's the denominator of the denominator goes on the top. If you make this mistake and you divide by body surface area, you will change the management of the patient and you will completely get it wrong. Now, going back to the distinction between pre and post capillary. Simply said, from normal, where you have low pulmonary pressures and a low transpulmonary gradient in blue with low pulmonary vascular resistance, precapillary has raised PA pressures with a raised pulmonary vascular resistance, raised transpulmonary gradient, but low again left atrial pressure, so wedge or left atrial pressure. If it is postcapillary, the pressures are again high as they were in precapillary. So in postcapillary, the pressures are high, but also left atrial pressure is high and the transpulmonary gradient is low. Now, it's not always like this in postcapillary pulmonary hypertension. You can have isolated, which is the way I showed it to you, so a low transpulmonary gradient. So the raised PA pressures are due only to the rise in left atrial pressure because of, let's say, mitral stenosis. Or you can have combined pre- and post-capillary pulmonary hypertension, where the pressures are very high, both due to a rise in left atrial pressure, but also to a rise in pulmonary vascular resistance. And this is important to know because in these cases, in isolated, if you relieve the left-sided obstruction or other problem, you may normalize PA pressures, whereas in this case, you can have residual pulmonary hypertension, which will, for example, after a mitral valve operation, can complicate things significantly for the RV and for the patient. When you think about transplanting a patient, heart transplant I'm talking about, so a patient with heart failure, a patient with congenital heart disease, you want to know what your transpulmonary gradient and pulmonary vascular resistance is, because you want to know whether you can transplant the heart only, or you need to do a heart-lung transplant, which is more difficult with availability of donors, and of course the outcomes long-term are not the same. So this is a little bit of a protocol that we use. So we look at transpulmonary gradient PVR and cardiac index, and of course if there are concerns, so there is some evidence of raised pulmonary vascular resistance, we challenge the patient sodium nitroprusside and or milrinone. When you perform right heart cath, it's important to have good quality control. We all know that the transducer has to be at mid-chest level. That's what the guidelines tell us for pulmonary hypertension in order to get the right pressure. If you make a mistake and it's too high, you will get a spuriously low, so pressures lower than what they really are. If you put it too low, they will be higher. So very important. I know our technicians and our cath lab techs and nurses do this for us, but always eyeball it at least and make sure that your transducer is at correct level. There's an issue with damping. You don't want to over dampen your waveforms. You want to see your waveforms. You don't want to have too many reverberations, for example, from the RV. You want to be optimally damped, and there are some tricks like inserting a small bubble or electronically dampening your waveforms. So this is very important as well, because this can alter your measurements, and this can also alter your measurements. Let's go to some fundamentals. First thing you measure when you get in there with your catheter is your right atrial pressure, which has various waveforms: the A wave and the C wave. A wave being the atrial systole. You have the X descent, which is the relaxation of the RA and downward pulling of the tricuspid valve annulus. You have the V wave, which is very important because it is the RV contraction, and the Y descent, which is the tricuspid valve opening and the right atrium emptying into the RV. And of course, you have an elevated A wave with tricuspid stenosis, but also with pulmonary hypertension. You have a canon A wave when you have third degree AV block, and the atrium contracts at the same time as the ventricle, the closed tricuspid valve. An absent A wave, of course, with atrial fibrillation mainly, and the elevated V wave we see very often with significant tricuspid regurgitation, and of course equal and A and V waves with tamponade constrictive physiology. I would urge you, this is something I discovered this year. This is free. It is the Wellcome Trust collection. It is a video from, I believe, the 1960s by Paul Wood on an interpretation jungle of venous pressure. I wish I had seen this when I was a medical student. And it was enlightening even to me now after so many years. So I invite you to go and look at this free video. The second most important measurement, actually another very important measurement, probably the most difficult measurement to make in right heart catheterization, is the wedge pressure. I'm not going to talk about the PA pressure, which is of course very, very important, probably as important as all the others, but the difficulties that we encounter is usually getting a nice wedge pressure. You need an end-hole catheter, and you need to have absent flow. You need to see something like this with all the waveforms. So what we are doing, just to remind the more juniors in the room, is that you inflate your balloon, you have your end hole, and you create a static column of blood that goes through the small pulmonary arteries, the capillaries, back to the small pulmonary veins and to the larger pulmonary veins. And hence physics tells us that with a static column of blood, the pressure at the tip of the catheter, which is what you're measuring, will be equal to pressure down here. Remember, if the patient has pulmonary veno-occlusive disease, so there is an obstruction to flow in the little veins down here, because the flow is static through the pulmonary veins, the wedge pressure will not be high. So the wedge pressure that we measure will reflect pressures in the left atrium, in the larger pulmonary veins. They will reflect stenosis in the pulmonary vein here, but not stenosis in the venules, which is what we see in veno-occlusive disease. Hence, veno-occlusive disease has normal wedge pressure. It is important also to have your wedge measurements in the mid or lower, especially lower areas of your lung, because of compression by the airways. This is just a small detail. Also to remember that the wedge pressure, we take it as equal to left atrial pressure, or LVDP, but there are exceptions like mitral stenosis and myxoma obstructing flow, chortriatriatum, etc. Now, when you do all these measurements and we measure the wedge pressure, and I'm not going to talk much about this, you want to unmask any diastolic dysfunction. You have a patient with left-sided heart disease, obese, diabetic, hypertensive. You go in and they're quite dehydrated because, number one, they're on diuretics. Number two, they've been nilled by mouth for the catheter for overnight. And hence you go in and you find the wedge which is normal. Some people say you should be giving some fluid to challenge this and see if the wedge goes up. Unfortunately, there is no evidence to support this, and experts do this, but there is no evidence on how much to give and for how long. Certainly, if you do this, you need to be careful to monitor your pulmonary wedge pressure, not to have an overshoot and send the patient to pulmonary edema. What they do tell us about diastolic dysfunction and pulmonary hypertension due to left heart disease is that we should be looking at the patient, as I said, to see for risk factors such as age, advanced age, obesity, being in atrial fibrillations or large left atria, structural left heart disease, if they're in AF, or they have LVH, and so on. So look for clinical signs for a pre-test probability of left heart disease. And then when you go and do your right heart catheter, then if there are any doubts and the wedge is borderline or increased, then you need to use your pre-test probability to find out if this is truly just post-capillary pulmonary hypertension or there is a significant precapillary component. This is still a matter of debate and quite complicated. Certainly, the guidance says we should not be using PH therapies in patients with group 2 pulmonary hypertension. So we should, however, be focusing on the left heart, as I said, aggressive therapy if you have heart failure, optimizing volume status. We should not be doing vasoreactivity testing. I'll talk about this a little bit later. And we should not be treating PH therapies. The other thing we do with the catheter is to detect shunts. So we do serial oximetry from IVC, high and low SVC, to detect anomalous pulmonary venous return or sinus venosus ASD in the atrium, in the right ventricle, and up in the pulmonary arteries. And you can have shunts in all these levels, and you see a step up in saturations. This is an example. You have a patient with an atrial septal defect. You see the left to right shunt. The saturations go from mixed venous of 60 up in the IVC and SVC to going up to 80%. So there is a left to right shunt. Now, when we do our oximetry run, we want to know if there is a shunt, and we need to calculate the shunt, and we use the QP/QS, so pulmonary to systemic blood flow, which of course in the left to right shunt will be higher in the lungs, higher flow in the lungs than systemic circulation, and we do that with this formula with saturations only in the aorta, mixed venous, pulmonary venous, and PA. The mixed vein saturation, so the baseline, so what is the return saturation, venous return saturations. This is the formula that we find in books. Most of us use just high SVC sats because, as you see, this is the most important. Also, you can have reflux of saturated blood, so mixed blood into the AVC, you have tricuspid regurgitation. Of course, there are exceptions to the rule. As I said, if you have an ASD, you have a step up in the right atrium and right ventricle and then pulmonary artery, so you go from a high SVC of 60 to 80, for example, like the previous case. But if you have a anomalous left upper pulmonary vein, you need to be wary that your high SVC will already have mixed blood, so you need to go somewhere else to get your mixed venous and calculate your shunt. How do we calculate cardiac output? There are three ways: the FIC, the thermodilution that many of us use, and cardiac MRI, of course, if you have a hybrid lab. The best possibly is cardiac MRI, followed by FIC direct, and followed by thermodilution, which, however, does not apply in patients with shunts. Thermodilution, we all know, we inject cold saline in the proximal port of your catheter, and you measure the temperature in the distal port, but it can be unreliable with tricuspid regurgitation, but also with shunts, left to right shunts. If the low cardiac output is too low, then the heat from the walls of the heart can hit the blood and give us overestimation of cardiac output. And of course, we should not be holding the syringe in our hand for too long. The FIC says that FIC principle says that the oxygen that the patient absorbs is proportionate to the oxygen content change from the pulmonary arteries to the pulmonary veins. So pulmonary arteries have 70%, for example, saturation. They go to 98 when they come back from the lungs. So this change in oxygen content is proportionate to the oxygen absorbed by the patient. And of course, knowing the VO2, the oxygen absorbed, and knowing the change in oxygen concentration, you can calculate flow. And the same you can do the systemic circulation. To do direct FIC, which is the more appropriate, the more accurate, you need a machine like this to measure oxygen consumption rather than taking it from nomograms. So this is what we do. We use the FIC method to calculate both our pulmonary and systemic circulation. And this is useful for patients with shunts mainly, to calculate QPQS, or only QP for all our PH patients, calculate your PVR. Some quick examples. This is a patient with pulmonary hypertension, which we found was idiopathic. You have a fairly raised right atrial pressure with a significantly raised mean PA pressure. The wedge was normal. The pulmonary vascular resistance was 11 Wood units. So this is precapillary pulmonary hypertension. This is another patient, this is a congenital patient with multiple previous operations, coarctation, subaortic stenosis, and right atrial pressure was high at 12. The wedge pressure was very high with a mean of 25. And the PA pressure was high at 34. And when we calculate pulmonary vascular resistance, it was 2.6. And you can see that this is a patient with high PA pressures, but high wedge. This is post-capillary, pure post-capillary, isolated post-capillary pulmonary hypertension. This is another young patient with tetralogy of Fallot, repaired previously, and had the pulmonary valve replacement. You can see the pulmonary valve, you can see previous sternotomy, the apex was going up because of right ventricular dilatation. And what we found is that this finding of constrictive pericarditis. Indeed, you can see that the PA pressure is raised, but also the wedge pressure and the right atrial pressure are very raised, and you have this characteristic dip and plateau here, or square root sign. Indeed, the op note said there were extremely dense adhesions due to thickened pericardium. Another case, again, this is the ASD case with the dilated pulmonary arteries and heart and the right ventricle. And when we have cases like this, we need to know whether we should be closing the defect. And these are the guidelines that tell us that you need to look at PVRI or PVR. PVRI is easier. If the PVRI is less than 4 Wood units times meter squared, you should be closing it. If it's more than 8, no, because then the RV may fail. Between 4 and 8, you've got a gray zone of uncertainty. So let's take an example. A patient saturations we found go from 65 to 85 because of a shunt at atrial level. We calculate a pulmonary blood flow of 8.4, and we calculated the QPQS of being 2.3, so significant left-to-right shunt. Let's take two examples. Let's say if the patient had a mean peak pressure of 30 millimeters of mercury. We will calculate transpulmonary gradient with a weight, let's say, of 10. We'll get a PVR of 2.4. So a patient with a mean peak pressure of 30, which falls into the definition of pulmonary hypertension, has a normal pulmonary vascular resistance, and hence we would close this defect because this is not pulmonary artery. This is not pulmonary vascular disease. There's no pulmonary vascular disease. However, if the PA pressures were higher, let's say 48, then we would calculate PVR of 4.4 or 7.2 Wood units times meter square, and this would fall well within the borderline, the gray area, more towards the prohibitive area. You need to really think before closing this defect because you can do harm to the RV, and this falls onto experts deciding on whether to leave it open or to close with a fenestration. Indeed, the guidelines, the LISTEN ACST guidelines, tell us that if you have an atrial septal defect, you need to look at your pulmonary vascular resistance. If it is less than, less than 5, things should be okay to close the defect. But if it's more than 5, then you need to perhaps try with pulmonary vasodilators or try again to decide whether to leave it open or close with a fenestration. Vasoreactivity testing is to test whether your PVR drops, and it is indicated in the idiopathic, familial, and drug-related for understanding whether patients should be treated with calcium channel blockers or for congenital heart disease for reversibility, for operability. This is what the guidelines say. If you have a vasoreactive idiopathic patient, for example, then and his PA pressures drop below 40 and by more than 10, then you should be treating with calcium channel blockers. And these are different to the criteria with congenital patients. I'm not going to go into detail, but again, remember the indications are different in congenital patients where calcium channel blockers have no role, and in idiopathic patients. Our hemodynamics are also important when we're dealing with patients who are failing, with the RV which is failing. We know that physiology says that in pulmonary hypertension you have an afterload increase. First you have adaptive hypertrophy, but as the RV starts to fail, the patient gets into trouble with low cardiac output, hypotension, raised right atrial pressure. So you really need to know what your pulmonary vascular resistance is and how you can target it best with PAH therapies. You need to know what your RV contractility is and whether you need to target that, and you need to know especially what your right atrial pressures are and to optimize preload to the RV. And of course, if there's hypotension, you need to avoid hypoperfusion of the RV. More advanced cardiac catheterization can give us more about RV to PA coupling. I'm not going to go into arterial elastance, just to remind you that if you have special PV catheters, you can calculate your elastance, so your coupling between the RV and the pulmonary circulation. And finally, let's not forget when we're in there and we have a patient, for example, with chronic thromboembolic pulmonary hypertension, during your right heart catheter, you probably want to be doing invasive pulmonary angiography, especially if your CTPA or MRPA have been suboptimal. And of course, there is now this new technique where you can actually dilate stenosis in patients with CTF, who mainly those who are inoperable, and you can do that percutaneously. Finally, again, it's important that right heart catheterization should be performed in expert centers who do enough numbers. We all know the theory, we all know how to do it, but doing it a lot is very important. Interpreting lots of these cases is very important. That's why in the UK we have only few centers doing pulmonary hypertension who prefer either in their centers, but also in shared care centers, large shared care centers in the network, that those centers should be doing the right heart catheters. Thank you very much.